Today, class, we're going to be talking about confusion and dementia. So when we're looking at confusion, we always want to know whether it's something that is acute, something that happens suddenly, or if this is a long-term problem. So when we look at aging and the nervous system, it is normal as a person gets older to lose some nerve cells. And it is also normal for nerve conduction to be slowing down, which makes a person's reactions a little slower. Vision and hearing can decrease, and taste and smell decrease as a person gets older as well. So because blood flow is decreasing a little bit to the brain, because remember our circulatory system, our vessels don't expand and contract, we lose elasticity, we don't get as much blood flow up to the brain. That's one of the reasons why these changes start happening with the nerve cells and the conduction system slowing down. Sleep patterns tend to change. Normally, as a person gets older, they require less sleep. I know that's not always what we see, especially in a nursing home. A lot of times you see people that just sleep continuously, but a lot of times that's depression that links into that as well. But normally, as a person, when they get older, they need less sleep. Forgetfulness it can start occurring because of all of these changes. And some people, their sense of balance will start being impacted. They might have mild dizzy sensations when they get up quickly. They have more tendencies when a person gets older for orthostatic hypotension. But one thing we have to keep in mind is mild forgetfulness, that can be a normal part of aging. Dementia, loss of cognitive function, that is never considered normal. That is never considered a normal part. So our cognitive ability, or when we talk about our cognitive function, it involves knowledge, memory, our thinking, our ability to understand things, to have reasoning ability. It impacts our judgment and our behavior. And so forgetfulness, we said, can be normal as a person gets older. Loss of cognitive function, their ability for rationalizing, for judgment, for what they're doing, that is never considered normal. So confusion is something that we always have to look at. Confusion. Is it something acute, something that comes on suddenly, or is it something that has been a long-term process with loss of cognitive function, something like dementia, Alzheimer's disease? Acute confusion occurs suddenly, and it is also known as delirium. It is always abnormal. It is always abnormal, and it is usually a sign of something critical going on in the body. So it's not something you want to ignore. When a person has an onset of confusion, we want to make sure we're getting them help as soon as we can. Delirium or acute confusion is usually temporary, and it's caused frequently by infection, infections that go throughout the system, illness, injury. Medications can do this, and surgery. So our treatment is going to be aimed at the cause. So you want to make sure when a person has acute confusion, and this is something new for them, that we let the nurse know right away that that it's getting looked at as to why this is happening. Because if we ignore it, it can be being caused by physical changes, and then if we don't fix them, if we don't take care of it, it can end up causing permanent damage. So when we are caring for someone who's confused, especially someone that has acute confusion, we always want to think of safety, making sure that their environment is safe for them, making sure that we are looking at having their call light in reach, speak clearly, face the person when we talk to them. We're going to need to call them by name each time, and we'll probably have to remind them our name each time if they have acute confusion. We reorient them frequently. Now, this is a little different than a person who has long-term cognitive function loss like dementia. When we're talking about reorient them, if you are confused, if you have acute confusion, I'm going to reorient you as to where you are, why you are there, what's going on with you. If you have loss of cognitive function, where this is going to be a chronic pattern for you, yes, it's not that I won't remind you who you are or where you're at, but I'm not going to constantly be trying to correct you. And we'll talk about that in more detail when we talk about the dementia patient. But for an acute confused patient, that is something we will reorient them frequently to what's going on with them. We're always going to explain what we're doing. Keeping calendars and clocks in easy to see areas are a good idea for people that are confused, and being consistent. When a person does have confusion, long-term or short-term confusion, following normal routines, trying to be consistent in their care sometimes can be very helpful. So this is an example of what you might see for a person in a nursing home. We generally will have big calendars up on the wall that will have what the days are, what type of activities are going on during those days. So it's easier for them to see and easier for them to be reoriented to date and time. Now, when we look at a dementia patient, so we have that acute confusion patient who's a delirium patient, and then we have long-term issues where we have loss of cognitive function. Dementia is loss of cognitive function when it interferes with routine personal, social, and occupational activities. Dementia is a group of symptoms that can occur with certain diseases or conditions, and it is never considered normal. It is not considered a normal part of aging. Some of the warning signs, early signs of dementia, is recent memory loss that can affect your job skills. So not being able to perform your job skills, things that you normally routinely do on a regular basis. Having problems with common tasks. You can't remember how to do things that you've been doing for years that you've never had any problem with. Problems with language, forgetting simple words, or getting lost in familiar places. Misplacing things and putting things in odd places. So I remember the first time I put my Cheerios in the freezer and my ice cream in the cupboard, I was convinced I had onset dementia. But when you go to the doctor and you try to convince them at 30 years of age, at the time when I think I first started doing that I had dementia, you have to remember that your brain can only handle so much information at one time. It was pointed out to me that when you are just stressed or you have a lot of things going on in your life, it's easy to do that as well. So I'm not saying that every time you misplace your car keys that you've got dementia coming on, but that is one of the early warning signs. Personality changes or poor or decreased judgment, loss of interest in life can also be a early onset of dementia as well. Okay, next we're going to look at with our, I liked this cartoon. It says, I remember the face, but I've forgotten your name. The problem is when a person does start getting dementia, as it progresses, as it becomes more of a chronic phase, they remember past memories. They remember themselves when they were younger. They don't necessarily remember what they look like now, and sometimes just even their own image sometimes can scare them. Alzheimer's disease is the most common type of dementia. There is a subset of dementias. So dementias actually is like a large umbrella of loss of cognitive function. Alzheimer's disease is one pathway of that umbrella. So it's the most common type of dementia where nerve cells that control intellectual and social function are damaged. And these functions can impact, again, your memory, your thinking, your reasoning, your judgment, language, behavior, mood, personality. Okay, all of those things can start being impacted when a person has AD. I thought this was cute. It says, after many years of therapy, Waldo finally finds himself. Unfortunately, with patients with dementia, when a person has dementia, it can be, for instance, vascular dementia. It can have happened from a stroke. You can have dementia that's caused by, certain disease processes that if you can fix those disease processes, it can help improve the dementia. Alzheimer's disease, there is no cure for it. It isn't ever going to get better. At least at this point in time, there's no cure for it. So a person that has Alzheimer's disease, it will eventually lead in death. So the risks increase with age, and the exact cause of it is unknown. One of the theories behind it at this point in time is that they have found that there's these tangles and twisted protein fibers that build up in the brain. And there's also what they call plaques, these protein pieces that build up in the spaces between the nerve cells. So they have found that those, and unfortunately, as far as finding these things out, they don't even find this until they can look at the brain after the person is dead. So the tangles and twisted proteins, normally you have your neurons and you have your synapses, and it can spread the impulse from one to another. But when you have these neurofibril tangles inside the neurons and these amyloid plaques in between the neurons. It keeps those messages from spreading and from passing to each other. As far as signs and symptoms of Alzheimer's disease, there's gradual loss of short-term memory, asking the same questions over and over, repeating the same stories over and over, forgetting how to do normal tasks, getting lost in familiar places, neglecting hygiene, and being unable to answer questions. So behaviors that are common with your AD patient, worried and angry, okay? They get very agitated. Their personality actually can start to change, and they get very angry very easily, and some of them will start showing tendencies for aggression, combativeness, even screaming. Wandering is another sign that we see with Alzheimer's. We actually have a code. Code green is patient elopement, meaning the patient has wandered out of the facility. So a lot of patients with Alzheimer's disease, they do wander and they get lost. They don't know where they're at. They're trying to find their way home. They're trying to wander back to home, but they don't know where that is anymore. And so one thing you're going to see in a nursing home is a lot of patients that have dementia that do tend to wander. They will wear a bracelet that will alarm when they try to go out the doors, so people will know that someone is actually wandering out the doors that shouldn't be. So the only time facilities are allowed to be locked facilities is if the facility only takes care of dementia patients. It is a dementia facility. They are allowed to have locked doors, locked in and locked out, to keep wandering from happening. But if you work in a nursing home that takes care of all types of patients and you have a patient that wanders, the best you're going to be able to do is put a type of alarm bracelet on them so it will alarm when they go out the door without someone going with them. Sundowning is another very common thing with Alzheimer's disease. It's when the signs and symptoms and behaviors increase during the hours of darkness. And they don't know if it's just from overstimulation during the day, that the person was overly stimulated and that's why this has happened. But they find that people with dementia or with Alzheimer's disease usually do better in the morning. And as the day progresses, they start getting more agitated, more upset, more tendency to have aggression or combativeness with their care. Hallucinations are seeing, hearing, or smelling or feeling something that is not real. Delusions, which are false beliefs. And then a lot of patients with Alzheimer's have catastrophic reactions, meaning they have extreme responses to things. You try to clean them up and all of a sudden they're screaming or yelling just over something very simple. We've already talked about the agitation and restlessness and that potential for the aggression or the combativeness. Another symptom common with Alzheimer's disease is depression. So a big tendency for these people to have depression as well as all their loss of cognitive ability. And then abnormal sexual behaviors is something that we see sometimes with Alzheimer's patients. But one thing I want to make sure that you understand with abnormal sexual behaviors, if you have a patient in the nursing home that is displaying evidence of sexual behaviors, they're touching themselves inappropriately, they're masturbating, you want to take them into their room. You want to make sure that they're not in a public place, where dignity is going to be compromised. So just wheel them back into their room, and you can shut the door. But the other thing you have to keep in mind is when someone's touching themselves, they're rubbing themselves, sometimes it's poor hygiene. Very well documented that patients with Alzheimer's disease tend to not want to get clean, they don't want to have routine hygiene done for them. And so a lot of times they're touching themselves because they get yeast infections, or, they really need just good pericare, and they're rubbing themselves because they're itching or they've gotten a type of infection just from poor hygiene. So keep that in mind too. When you're starting to see abnormal sexual behaviors, you do want to check and make sure they haven't gotten a urinary tract infection or a vaginal infection, that there's not just a cleanliness issue going on. Alzheimer's has no cure at this point. So we always have to make sure we're providing comfort and safety. We're preventing skin breakdown and contractures, and we're treating these people with dignity and respect. Range of motion, keep them active, keep them moving, and it will eventually end in death. So we need to make sure as they're approaching that we get hospice involved in their care. And as I mentioned, neglecting hygiene is really common. So infections, they're a big risk for infection because of this as well. So we're going to stop here.